this session. And the recording is starting now, and that recording will be posted to the Michigan chapter of HIMSS YouTube channel. Before handing things off to our panelists, we'd like to take a quick opportunity to acknowledge and thank our annual sponsors, including the sponsor of today's webinar, the MyHIM Group, for their continued support. Our sponsors allow us to offer information, educational, and networking opportunities and thought leadership to our membership throughout the year, and they are integral to our chapter success. And now it is my great pleasure to introduce the moderator of today's session. Chris Bailey is the Director of National Engagement and Consumer Health Strategy at the Michigan Health Information Network, MyHIN. Chris has over 20 years of experience working in the healthcare IT sector. He currently serves as a Director of Business Development for Vellatura, the exclusive retailer of MyHIN products and services outside of Michigan. His work focuses on building client and partner relationships to support collaborative, innovative opportunities. Chris is also the founder of CareConvene, a virtual healthcare service provider that not only extends a brick and mortar doctor's office, but also focuses on patient literacy. Welcome to Chris and the panel. And Chris, the stage is now yours to introduce our esteemed panel of speakers.
Sharon, can you hear me okay?
I can.
Excellent. Well, thank you for that overly generous introduction. Appreciate it. I'm going to turn right around and thank you and Lindsay at Michigan HIMSS, as well as Katie and Nazi at MyHIN for helping me get this event pulled together. We were originally planning to talk about, general telehealth, but this has pivoted into a larger conversation about consumer digital health, and we've brought in a couple of our trusted experts that we work with on a regular basis. So I do have to thank those trusted experts, our panel speakers. They have a lengthy career experiences in healthcare, provider engagement, and consumer brand strategy. With this participation, we hope to provide a more conversational learning experience for all of you today. The session will be broken into two topics, one lesson learned from the COVID pandemic, and then post-pandemic preparation for healthcare delivery in the future. And I'll be asking each of the panelists a question for each topic. We're going to hold about 10 minutes at the end of the session for questions. And so our Zoom moderators will help us tee those questions up at the right time. There will also be a poll towards the end, towards one of the speaker questions. So look out for that. Sharon, feel free to tee that up at the end. So let me first introduce Dr. Gretchen Goltz. Dr. Goltz is a regional medical director with provider engagement at Blue Cross Blue Shield in Michigan. She's enjoyed a fulfilling career as a family med physician at Muskegon, in the Muskegon community for over 19 years. She's energized by change leadership and lean management processes, which brought her to her current position with Blue Cross. She enjoys the challenge of developing ideas and processes to enhance provider and patient experiences. She's married to a firefighter and has 2 grown children. And as I just learned, a whole bunch of animals to take care of as well. She enjoys exercise, gardening, and reading. Our next speaker, panelist, is Kevin Budelman. Kevin is interested in strategic design for business, education, healthcare, and society. Kevin is a president and co-founder of People Design, a strategy and human-centered design firm based in Michigan for over 25 years now. Besides serving as an advisor to his clients, he's an adjunct professor at Northwestern University and the former global president of Interaction Design Association. He holds degrees from Carnegie Mellon University, ITT Institute of Design, and he also has a book called Brand Identity Essentials. It's available in 6 languages and is on its 2nd edition. Last but not least, Dr. Kevin Bohnsack. Dr. Bohnsack is a board-certified family physician at IHA Mylan Primary Care. He's also a medical director for Southeast Michigan Clinically Integrated Network. So a lot of experience in value-based care as well. His passion for patient safety and transitions of care have led him to several leadership roles and patient advocate positions within Trinity Health. He serves as the state air surgeon with the Michigan Air National Guard, applying his background and training in aerospace medicine to oversee medical standards and qualifications for over 2,500 personnel, providing technical expertise and recommendations for the ongoing COVID response and other domestic operations and support and mentoring of current and future leaders. So it's definitely my pleasure to be on a slide with all three of these experts. I've known them for a while. I've learned a lot from them over the years and look forward to many more learnings. So our first topic is lessons learned in the pandemic. We want to take a look back. I know there's been a number of sessions out there in the industry talking about telehealth. It's sort of getting old, so we wanted to sort of reinvent the topics. And so we've broken this session down, kind of looking back at the pandemic in the past. And my first question is around provider engagement, and it's to Dr. Goltz. Prior to the pandemic, payers were reimbursing for virtual visits, but it wasn't until the disruption in care delivery from COVID-19 that providers began actively using these billing codes for obvious reasons. What has Blue Cross Blue Shield of Michigan done to support provider engagement of virtual health, given the sudden and dramatic increase in need? What were some of your biggest lessons learned from a payer perspective over the last year?
Great. Thank you for that very nice introduction, Chris. And I'm excited to be joining these other two gentlemen on this panel today. It's going to be a great use of our time today to talk about these topics. I think if we kind of step back before the pandemic and look at where we were at with virtual visits and telemedicine, they did a study in 2016. It showed about 40% of physicians were doing telehealth. And then looking at 2019, it had increased to about 28%. And common challenges were reimbursement, licensure, and the ease of use of some of these platforms and how do they integrate or not integrate with our electronic medical record system. Before the pandemic hit, we looked more closer to home at our physician group incentive program providers and saw that only about 9% of them were providing any telemedicine services, and the majority of our patients were experiencing telemedicine through a national vendor. And COVID-19 hit, and the policies are rapidly changing. And at Blue Cross, what we did is we set up weekly webinars to meet with our provider community and talk about COVID. And in that, we talked about telemedicine and coding and billing, and provided education and support just to help them bring their practices on board. And through that experience, usually within 3 months of into the pandemic, we saw an increase to about 85% of our practices providing telemedicine services. And that was very important. And we did place some incentives to help them afford those costs. And at the beginning, we did allow them to have any HIPAA or non-HIPAA compliant platforms. And we'll talk a little bit more about that later. But then we also have incentives in place to encourage them to transition over to HIPAA compliant platforms. So some of the lessons learned, I think, through the pandemic, I think we all learned that we can pivot quickly when we have to and come together and work together jointly in a very short amount of time. But I also think what we're seeing is as the pandemic, that first wave started to wane, we saw physicians and patients gravitate back to their level of comfort in the in-person visits. And we have seen a pretty significant decline in telemedicine from the beginning of the pandemic. But what we have seen as a shift is most of our claims for telemedicine are now through their primary care physicians rather than the national vendor, which I think goes to show that patients would really prefer to have this telemedicine experience with a primary care physician.
Yeah, Dr. Goltz, that is, I think that's one of the most exciting things about the pandemic, because I certainly know prior to COVID, it seemed the national carriers got a lot of traction with large health systems who were looking at outsourcing these services because just the complexity of putting this into place. And the pandemic has certainly shown with reimbursement that clinicians can provide quality care via this interaction. So it's exciting to see that the increase from 9% to 85% has hit our primary care practices. That kind of leads me into my next question for Kevin Budelman. And the healthcare industry didn't experience the pandemic lockdown in a vacuum. Every other industry, from hardware stores, general retail, food, and other services, had to pivot to meet requirements for social distancing and limited contact to simply survive. Many of these industries had already embraced digital technology to support payments, orders, delivery, et cetera. My question to you is, how has the acceleration of these technologies and non-healthcare related industries impacted consumer expectation for all types of consumer experiences? And what might be the implication for healthcare? Just kind of wondering, healthcare not being in a vacuum is being disrupted even by other services who are providing a high level of touch to their consumers. So I'd love to hear about that. We can't hear you, Kevin. Make sure you're off mute.
There we go. How many unmutes do we need?
There you go.
You hear me now?
Perfect.
Okay.
I can hear you.
I just want to say, thank you very much. I'm honored and humbled to be part of this group and part of this conversation. So thank you. And thank you for the question. I think one way to think about the changes that we're experiencing right now is to perhaps step back just a little bit. Among the topics that I teach in my classes and work with clients on is the idea that, if you step back a little bit, we're kind of moving on a societal level from kind of this industrial kind of era to kind of an information kind of era. And
I'm sorry, Kevin.
Yes.
This is Sharon. There is some feedback on your line, so maybe you need to mute your computer.
Hopefully that's working. Is that okay? Yeah. Is that working, everyone? Can you hear me?
I was hearing you fine, Kevin. I actually heard more feedback when Sharon piped in.
Okay. Okay. I'll continue. You can interrupt if it's difficult. So I apologize for any trouble. I was just going to say that as we think about trying to emerge from kind of this industrial era, most institutions and most industries are kind of built in kind of an industrial mold. And I think that's true within healthcare. But I think like a lot of industries, healthcare is starting to realize that, hospitals aren't really like factories and patients really aren't like parts on an assembly line. A way to think about technology and telehealth and some of the things that we're experiencing now is that, technology is what we call things that were invented since we were born, right? So anything, so things that were invented before we were born, we don't call technology. So we don't tend to call the washing machine technology, but we consider a mobile phone to be technology. But I guarantee you that my teenage daughter doesn't consider the mobile phone to be technology. That's just her life. And so I think what we need to understand is that the rate of change is increasing. So we're seeing more and more sort of new technology enter our lives in many ways. And, new norms are emerging for how people think about experiences. And, basically consumers armed with information have more and more power. They have more and more choice. It's led to globalization and technology innovation in a lot of spaces. And so we're really at the place where consumers kind of vote with their wallets, right? They vote where they want to go based on better experiences. And the challenge for a lot of organizations is that, competitors don't benchmark you against your same industry. So even within healthcare. So people don't necessarily benchmark a healthcare experience with another healthcare experience. They want the search on the healthcare website to work like Google. They want the retail experience to be like Apple, and they want the delivery experience to be like Amazon. And this is a tall order for a lot of organizations. And ultimately, consumers will vote by which experiences they choose, and they'll choose the ones that are the most convenient. They'll choose the ones that are the most meaningful. And the reality, of course, is that change is very hard, right? I mean, and most organizations will need to change more rapidly and more significantly than is comfortable. But we're all in this together. So healthcare is in one state of evolution. A lot of industries are in different places. As a consultant, we often almost look at it almost like as carbon. You can almost carbon date, different segments of the marketplace depending on how far they are along in their realization that they need to change. And healthcare, on the whole, has not been largely disrupted like bookstores or taxi cabs, but it's surely coming, right? So as I think about this is what was all happening before the pandemic. Now the pandemic, has been this essentially a huge accelerator on a lot of fronts. And it's led to a situation where it's created disruption, it's created opportunities. But I think what's helpful, the way we think about it, is that there's a common kind of innovation strategy that involves the idea of trying to take one element out of a system as a way to sort of innovate and come up with new ways of solving problems. And what's really happened with COVID is that it's created a dynamic that suddenly has removed face-to-face interactions for a lot of kinds of businesses, and a lot of companies that were already starting to move toward digital transformation were better prepared than others. I'll put that aside.
Thanks, Kevin. I have a question I'm going to tee up for sort of your second question, is give you some time to think about that. Is, when we think about brand meaning for, Wendy's or the Home Depot, think about what does that mean for providers in the future? Not necessarily large health systems, but providers, payers. So very interested to hear your input on that. But from what you said, it definitely leads quite well into the question I had for Dr. Bonzak, who's, seeing patients on a daily basis, and those patients are experiencing that rate of change and experiencing new norms outside of their healthcare interaction. So Dr. Bonzak, as a practicing physician and someone who has their eyesight set on a clinically integrated network that's, probably at risk, what has your experience been with virtual care, and how has telehealth during the pandemic impacted your patients' attitudes and their expectations on care? Has it changed? Is it evolving, or are we not there yet? Are your patients not there yet with their expectations? Certainly, they've been frustrated, I'm sure, for a long time with access to EHRs and things like that. But I'm curious your thoughts on that.
Yeah, so thanks for the comments up until this point. Kudos to Gretchen and her team and other payers for acknowledging that we did have to shift on the local level, right? Because we certainly, as a clinically integrated network and as providers of care, we don't like to see things outsourced to national providers when we like to think that we can deliver it locally. But as Kevin pointed out, we had to have an accelerant to that, and it ended up being a pandemic. Biggest pandemic in over 100 years, right? And so with that, that really allowed a moment where we had to basically step up to the plate and start thinking innovatively. So if you can see me on the screen, I look like I'm in my clinic right now, but I don't have a white coat on. But this is my virtual background that I actually use during Zoom visits with my patients to make them think that I'm actually in a clinic. But actually, I'm in my home office right now. But you've got the rubber gloves on the floor, on the ground, on the wall, and all those other things to make them already feel like they've got at least some clinical setting. But what does that really mean? I'd argue there's three main points to what we're able to see as drivers to our swift change to virtual health and televisits. Was, first of all, just to comply with public health measures, right? So we had to social distance, people had to hunker down, but we still needed to talk to them about their different medical care and their concerns. And so by improving that ability to adjust and see people virtually, that allowed us to comply with public health measures and not have people out on the streets. But secondly, from a safety standpoint for our staff and for our patients, it was reassuring to know that they could get care and not have to come into the clinic, because they were always worried, well, is the person in the waiting room sitting next to me maybe have COVID or something, right? So we were very disciplined in how we were scheduling patients to make sure that somebody with potential COVID symptoms was routed to a different center where we had basically sick and non-sick or well care, chronic visit care, where we didn't have to have exposures. And from a safety standpoint, that was a crowd pleaser, not only for the consumer, the patient, if you will, but also for our staff, knowing that we were standing up for them and making sure they were safe. And then lastly, back to that consumer aspect that Kevin already pointed to was convenience. I mean, people don't have to get in their cars. The opportunity cost of maybe just a 20-minute visit at a doctor's office really is about 2 to 3 hours, if you think about it. Whereas no kidding, I mean, I saw patients that were, unofficially still, actually they were on the clock in a hallway or in a stairwell, in their car. That sort of thing was happening while they're still working. Just getting that quick little sidebar consultation with me as a doctor, but also for the elderly who have trouble coming into the clinic sometimes, I was able to meet them in their dining rooms, in their living rooms, their back deck. I met their pets in their fancy car they had in their garage, all those other things, which actually, you think that a virtual visit would be cold or less warm, if you will. We actually had some very rich interactions as doctors. And then also, again, with the elderly in particular, it was a balance because sometimes they couldn't do very well with their iPad or this other newfangled technology, as Kevin pointed out. But it would be an iPad from their daughter, their granddaughter, son, whatever, to be able to at least connect to the doctor and have that visit. And so in the end, I think we had some lessons learned where we could accomplish some things as virtual visits, refilling meds and reviewing chronic conditions. Again, some of that joy that we had of sharing more intimate places in their own homes, which is pretty awesome and very fulfilling. I'd say the challenges that we still need to work out are other data points that we rely on. So remote blood pressure cuffs or other data points that you might get from what we normally think of as vital signs, right? Vital means it's vital, it's needed. And so we're not always getting the data that are normally entailed in a patient interaction. And also some of those other immediate things. So if somebody comes in for a controlled substance visit and they want their narcotics, for example, we do a urine drug screen. Well, you can't do that. You can't say, hey, I can't prescribe that until you give me a urine sample when they're sitting an hour and a half away or whatever through their virtual visit. So some of those practicalities of how we do some medicine still needs to be rethought. And lastly, just practicing evidence-based medicine against back to Dr. Goltz's point about national vendors versus us standing up to the plate. I mean, we learned how to provide that personalized care in a way that I think patients appreciated. And now we're just trying to balance that and find a blend of what the demand signal is from the patient population, what we can supply, and how to put that together in some way where the convenience is balanced out with the medical needs that we have of seeing face to face. So I'd say this is a long time coming, and we've adjusted, fortunately, and now we just have to try to normalize that and look forward to future partnerships of doing that. Last shout out would be to behavioral health in particular, where I think we've learned a lot about, certainly under COVID situations, about people needing some help. And I think that's been another big bonus, is ensuring that people have access to behavioral health. And again, our behavioral health specialists out in the field have also learned how to adjust to that and be accessible to their patients.
Yeah, thanks, Dr. Bonsack. And what I'm also particularly interested in is as we evolve and improve in care delivery, how much can we utilize these same technologies for symptom reporting, triaging, navigation? I think all are probably equally important pieces to that clinical digital workflow. So I'm pretty excited about that. So our first topic here, we pretty much covered that, we now have reimbursement. We have support from the payers. Care has moved to the local PCPs and digital. We understand, and we've probably always known what customers wanted. They didn't quite expect it, and we have an idea of what this looks like in practice. Thinking more about the future, I know Kevin Budelman, talked about one of the key pieces to other industries is they've been preparing for, not necessarily preparing for this for a long time, but they've adopted technologies a lot sooner than healthcare did in terms of connecting to between patient provider. But one of the things I'm particularly interested in, as Dr. Bonzak, just shared his experiences inside the practice, is at what point and where does this advanced digital care team come into play? And so my second question for Dr. Goltz is, from my reading and my networking, it appears most of the virtual visits occurring during the pandemic were limited to a patient video interaction for urgent care types of interactions. But we know virtual health includes synchronous, asynchronous features that support all types of convenient patient clinical interactions. In my experience, providers in an in-person practice-based setting look to rely on the entire care team working at the top of their licensure. They want support. They want everyone in the care team, the MA, the RN, the NP, the PharmD, et cetera, working at the top of their licensure to deliver team-based care. What are your thoughts and predictions for the use of advanced virtual care teams as a model to support the future of digital health and consumer engagement?
Sure. I just to reiterate what you said, I think most providers and patients look at telemedicine as that, video appointment, and there isn't a lot of depth or range to what we have done historically with telemedicine. But as we do look forward into this more of an advanced care team model of practice, where we are leveraging all of our resources as physicians in our practices, from our medical assistants, our care managers, the pharmacists, even looking at some of the collaborative care for behavioral health with the psychiatric consultant and the behavioral health care manager. How do we integrate all of this together into that experience for the patient and leverage in-person visits and telemedicine visits? We all have the quick check-in type visits. We have secure texting, store and forward. All of those things can help layer in different experiences for the patient depending on what their need is for that moment. And then when we bring all of this together, they're going to have this kind of like the seamless experience. And, maybe some visits should just be telemedicine visits. Maybe what we use to bring patients into the office for, maybe we don't need to do that as often, and then that'll improve access. And so we'll have some, maybe a quick rash or some simple type visits taking place through a store and forward type interaction, and it's a lower cost visit for the member. It's a lower cost visit for the provider, but they aren't spending 30 minutes or 15 minutes or, having that patient wait for a visit to come in and take a look at something like that. And it's a quick visit that they can do in between some of their in-person visits that have to be seen face-to-face. And I also, just to move more into what Dr. Bonzak said about chronic disease management through telemedicine, there's a lot of opportunities with blood glucose monitoring devices and some of these other technologies as they, evolve and adapt over some time. Maybe I don't need to bring my diabetic patient in every 3 months for an in-person visit, especially if they're well controlled. Maybe I see them in person once or twice a year, and then their interim visits are done virtually. So I think there's a lot that we can do to help add to the experience for the patients. And again, currently right now they're just used to that basic interaction, but they're going to be looking for a more sophisticated experience that it's faster. I think gone are the days when a patient's going to call the office in the morning and be willing to wait 4 to 6 hours for a response to their call. They're going to want their responses much more quickly. And so do we look for that digital front door experience in the practices where patients can actually connect virtually or digitally to their physician and maybe use a symptom checker or an e-triage tool, or connect directly to the care manager or directly to the pharmacist or directly to the behavioral health care manager, and use the digital experience to help navigate their experience. So I think those are some of the things that we're going to need to look at as we move forward.
Yeah, it's going to be exciting. Having spent a lot of time supporting physicians and practices with technology and like in many instances worked well, because a lot of times those two can't be pulled apart. And we don't have a crystal ball, but I think it'll be very interesting to see what the economics of healthcare looks like in the next 2 to 3 years. Everything from what does fee-for-service, value-based contracts look like? Who's getting paid for what service in terms of the advanced care team, which roles and licensures are part of different arrangements. So I'm definitely looking forward to seeing how that plays out. Thank you for that response, Kevin. We're throwing it back to you. In the last session, we sort of talked about what industries had to do, but now as we look at healthcare and look at what healthcare needs to do to catch up, it's healthcare delivery is going to look different in the next few years. And as I mentioned, I think so will the economics around it be different. What can healthcare learn from other industries that have built world-class digital access for their products and services, and how is that going to really impact the consumer experience in general? And what does brand have to do with it? What last part? So it's all yours, Kevin.
I think it's worth noting that I think some of the changes that we're seeing now, a lot of people are anxious for things to return to normal, so to speak. And I think that certainly within a lot of spaces, and I'm sure this is going to be true in healthcare too, as Dr. Goltz was just referencing, some of these things are not going to return to whatever the previous state was. In fact, the longer this pandemic goes on, the more likely we are all to develop new habits, and we will have innovated in different ways. And some of these changes may be permanent. And some of them are because there are macro trends that were happening even before the pandemic, but also because of with this accelerant, it started to, change organizations in a lot of ways. I think it's helpful to, so healthcare, of course, I don't need to tell you all that, it's a huge, complex, highly regulated kind of industry. It's not going to move as quickly as some other kinds of industries, but we can definitely look to others for guidance as to how they are evolving. If you think about some of the technology leaders that are kind of the usual suspects, Amazon, Uber, Facebook, Google, Apple, they are obviously technology innovators, but the real hot topic right now in Silicon Valley is less about technology per se, and much of it is a focus on customers and their experience. And so while these products and services are innovative in their own right, a lot of them are capitalizing on technologies that are actually somewhat, fairly mature, and basically developing different kinds of use cases, different ways of providing value to their customers using technology. So if you think about it, it's really a triumph in trying to understand what people want and really need, and then using technology to deliver on those expectations. So that's truly what's going on, and I think that's the kind of thing we'll start to see in healthcare too. And there are emerging strategies for dealing with these things, right? So there are emerging practices, interaction design, customer experience modeling, user research, communication theory. How we think about these things is really critical. Even the words that we use regularly, like what's virtual meeting and what's the word webinar or telehealth. I mentioned this to our panelists when we were talking about this earlier. We often talk about how, so 100 years ago, you might have had a toaster. You didn't, but this is before electricity became as mainstream, right? So now we don't call it an electric toaster. We don't call it an electric this or that, but we use the word digital all the time. Here's a digital product. At some point, nearly everything will be digital, right? So I think we have to accept the fact that these things are going to become more and more part of our vocabulary. And I think, healthcare is not immune to these changes, right? So payers and providers, patients, so everyone will be expecting more based on these kinds of experiences. The kinds of things I would suggest that we, as providers, value to customers on various levels, whether they're inpatients or in between, is that products and services get blurry. Your customer doesn't care about your internal complexity, Competitors will come from outside of the marketplace. You'll have technology providers, whether it's Apple or Amazon, playing in the healthcare space. I think emerging technology, which may seem kind of aspirational right now, will be table stakes. So thinking about it as, these are things that will start to happen. And in part, there are financial drivers. I mean, part of it, if you think about face-to-face interaction, same time, same place, is the most expensive kind of interaction you can have with another human being. And we've taken these things for granted, but it takes a 1 in 100-year pandemic to sort of jerk us out of whatever stasis we're in to move into another place where suddenly asynchronous, remote services or delivering value in other less traditional ways are going to become more and more prevalent, in part because of the cost drivers. But ultimately, as it relates to the consumer, the patient, or B2B kinds of relationships all the way through the value chain in healthcare, everyone will gravitate toward brands or experiences or products or services that are truly helpful, that are easier, as Dr. Goltz mentioned, seamless, or even better ones that are more fun. That sounds kind of crazy, but it's really true. I mean, the relationship between information and entertainment is getting more and more blurry today. So, and consumers and buyers of all kinds will vote with their wallets, and the financial people will notice. So I guess if you think about it as, if we're all kind of in this moving river, on some level, if you don't keep paddling, you won't even keep up. You're going to fall behind if you don't keep paddling, right? You have to paddle pretty hard to stay ahead. But it isn't to be scary. Everyone's in the same place. They may be in a different place, but at least we're sort of paddling in this river together. And I think it's useful to recognize it's easy to look at Amazon as having the economy of a small country at this point. But it's also useful to recognize that they lost money for a decade before they got to where they are, right? So organizations need to invest. So they need to invest it with money, but it's also investing in kind of a different mindset, a mindset that's sort of based on agility and adaptability.
Thank you, Kevin. Yeah, it's exciting. I always enjoy learning about your research and work in other industries. The last and final question includes a poll. So Sharon, I know you're having some echo feedback. So if you want to pop up that poll, that'll take a few seconds. But while you do that, I want to sort of introduce sort of our last topic in question. So when you get a sec, go ahead and tell me what the P in HIPAA stands for. While that poll is taking place, HIPAA dates back to 1996. It was important legislation to support patient privacy for treatment, payment, and operations, but is much less reference for its original purpose. Dr. Bonczak, can you share what the P in HIPAA means to you as a practicing provider and the implications to improve patient engagement and health literacy? I think we got the results back. So I think a lot of people knew what the P stood for, but we often think of it as privacy because there's so much to deal with privacy in HIPAA. But Dr. Bonczak will talk to us about the actual portability benefits and the implication to, I think, patient engagement and greater health literacy through new technology. Dr. Bonczak.
Yeah, thanks, Chris. So again, in preparation for this webinar, I had posed the question to even our panelists here, and it doesn't surprise me. So 3/4 got it, 1/4 didn't. You guys are all pretty well informed as health informaticists. I'd be really interested to do that as a poll of other folks in the healthcare field. But I actually got even more creative in my, this is all rigged, right? We probably know what questions Chris is going to pose to us initially, but I thought for an outline of my last answer in my little sermon that I can preach here was to go through HIPAA word by word. It stands for Health Information Portability and Accountability Act, right? And so I guess I'd like to use those 5 words as an outline for some diatribes I can kind of throw out there, is where I really don't feel like we as a society are still centered on health. We're really still treating medical disease, and that's problematic on a lot of different levels. And I know we'd like to incentivize better behaviors, but one of my comments to patients, even when they're trying to lose weight and eat better, I say, well, what's cheaper, a bag of potato chips or a bag of baby carrots? And we actually know that we subsidize corn fructose syrup by subsidizing lots of corn out in Iowa, who by chance happens to be the state where they do presidential elections every 4 years for primaries, right? So we have some perverse incentives in our society for health, and that's well documented, of course. And with my master's in public health that I had the pleasure of pursuing, learned more about that. But in terms of insurance, again, we've got Dr. Goltz there on the line representing insurance, but parts of the insurance are actually also full of perverse incentives where you have what's called moral hazard. And this isn't saying people are not moralistic. Moral hazard means that certain risks that you might engage in are cushioned, if you will, by the coverage that you have. And so people are more likely, for example, to scream down a downhill slope if they have coverage for their orthopedic injury they might get. And if they don't have healthcare coverage, they might not go skiing. That's the moral hazard, the classic one you learn in school. But with that, it also means that you don't always see the effects of your own decisions right away. So you know that you can get your cabbage after you have your heart attack. You know, can get bariatric surgery if you've gotten to the point where you need that sort of intervention. Those sorts of things are available through insurance that then actually cushion you a little bit from some of your choices. And that's something where, like what Dr. Goltz is talking about, are there incentives we can bake into a new thought process of how we deliver care that can better give feedback to patients on what their choices are meaning and what the downstream effects are. The portability piece, mainly centered in the HIPAA Act originally, was about portability of insurance. So if you lose your job or if you're switching jobs, you can still have insurance. But a lot of that did center on data, which is why that misconception that the P is privacy is very tied into a lot of the things that are now mechanized in our information technology for protecting privacy. But that portability of data is still problematic. I mean, if I see a patient that is seen by a nephrologist that's outside my system and they've got some renal problems, I can't half the time know what their last basic metabolic panel showed and what their creatinine was, for example, because I'm in my own EMR, they're in their EMR, that back and forth. Whereas, you know, with your app for that, you can know what your banking accounts are looking like, just like that, right? So we have problems with that, but the patient portals are starting to make gains for that. The accountability piece is interesting because back to some of the moral hazard I was talking about before, patients are so actually I as a doctor get held by insurance companies for hitting certain squares for quality measures, for example. So if a patient decides they don't want their mammogram or their colonoscopy or some other preventive thing, I get punished by quality scores because they're not making a decision about that. So accountability right now is not really put on much on the patient, the consumer, if you will. But that's the whole aspect where healthcare is not a perfect market. Newsflash here, hopefully, or not. But it is not a perfect market, and we need to adjust to some of those things. And the last piece is the act, right? HIPAA is an act of Congress that was passed. And so the classic, I'm here from the government, I'm here to help, is one of those interesting comments that you hear. Being in the military myself, you hear, I'm here from headquarters, I'm here to help. But I really would say that the springboard for a lot of that is newer legislation that's been passed to incentivize with APIs and other ways that we can build a better platform of knowledge. And again, using that HIPAA aspect of outlining what the future could entail, wouldn't it be wonderful if we were centered on health instead of disease? In terms of the insurance, if we can align those incentives and make sure that people can tailor their decisions and know what the impact is. So, progressive insurance always brags about how you can get a cheaper rate if you don't have a car accident. Well, how can we incentivize better health behaviors that we know would be incentivizing that for, not smoking and doing other healthier things for your life? So the portability piece is really where IT comes into play, where, if you can do the same thing with your banking, you should be able to conglomerate a lot of those things all together and have access to that. And then, again, through that MyHIN technology that might exist or some other IT platform, you can build widgets on top of that actually give me real feedback. And one of my favorite acronyms is DRIP, Data Rich, Information Poor. I heard it from a mentor, so I didn't coin it. But we have a lot of data, but where are we making information out of that? Actionable information that we can actually do something about. And I would argue that a lot of what we plug into the EMRs is just atomic data, little data points, and they don't mean anything to the patient. And sometimes quite frankly, to the physician that's trying to make sense of it all. And so finally, with that, the last A of HIPAA being act, I really think this is a prime time to act. How can we align some of those incentives from the payer side? How can we take into account some of the consumerist movements that are happening and then center that on the patient and the physician relationship so that I can be better with my patients and actually bring them into health and better lives that I know that they want to enjoy for longer than what otherwise is enabled through what is frankly a disparate confederacy that is not a healthcare system. And so that's my parting shot, is to say, I don't use the term healthcare system, because if a system implies that you have deliberate design for a shared outcome and goal. We don't have a healthcare system. And so as we think about that, let's think about ways to maybe inject a few bits of outrage or at least enlightenment for our patients, our consumers, and get them to grab onto their health and work with leaders like we have in the virtual room here to make things better. Sermon done. Thanks a lot for the opportunity, Chris.
I appreciate it. Well said by all. So I'm optimistic and excited about the future. I think from everything from, leveraging these advanced care teams, leveraging everybody on the care team to the fullest extent of their license, their scope of practice. I'm looking forward to what we see now is daily news about investments in technologies. It's coming fast. But lastly, as Dr. Bonsack talked about, empowering the patient for literacy. Technology can be used for many things: treatment, triage, navigation. They're all incredibly critical pieces to healthcare delivery. And I'm really looking forward to seeing what the economics have to do with our new model in the coming years. So again, thank you all for participation. Each one of these 6 topics could have been an hour-long conversation in of themselves. So hopefully everyone got something out of this. We do have a few minutes for questions. I'm not sure if there are any out there, but happy to tee them up. Lindsay or Sharon?
Yeah, great. Thank you, Chris. That was a wonderful presentation. There are some questions that had came in. The first one is, you've talked about changes to consumers and patients. Are there discussions taking place about how to responsibly handle administrative support for remote providers to handle things that have happened in the office? For example, patient intake, discharge, accessing the EMR, claims and billing.
Dr. Bonsack, Dr. Goltz, seems like either one of you could probably,
Yeah, so I'll start with the discharge process if I was going to, center on that one. So I think I mentioned before that patient portals are gaining significant access for patients, and in fact, my own back and forth emails or not emails, but HIPAA compliant. Dr. Goltz, they are HIPAA compliant. Patient portals through our EMR are great because patients can just do that one-off question for themselves, but also through that, they have access to some of those documents that previously were basically shrouded from their own visibility. So discharge summaries, medication lists, things like that, I think are enabled through the patient portals. But again, they're still compartmentalized so that, if they're done in one healthcare system, and they got rendered care in somewhere else because they were traveling or they were just 10 miles down the road in a different EMR, they don't always see those things. And again, that's why I do wonder about the value of having an agnostic platform of some sort. But at least in terms of visibility on data and what instructions there are, I do think that patients' access to some of those tools has really increased their visibility and awareness. And in fact, with open charts, which is now required by some regulatory agencies, we're getting calls where patients are saying, "Hey, why is this diagnosis code in my system? I'm not an alcoholic," but they might have said at one time 5 years ago, "I drink alcohol. Can you check my liver tests?" Right? But to justify the coding, the provider put into their use of alcohol, and somehow they got, gonculated into alcoholic or something like that. So I actually think that's going to increase the visibility and engagement that patients have with their own care by having access to a lot of those information from the disparate information systems that we have.
Yeah, and with to add to that, since we're on the cusp of the patient access API CMS requirements, third-party consumer apps can pull all of these data pieces together, right? Why have a separate silo for your RPM data, biometric data, and having, I have my information in, I think, 6 different EHRs over my lifespan, which doesn't even count the stuff that's all on paper because I'm that old. But, there's a huge opportunity to pull this all together to both, help spot check certain things, but also help that consumer better understand their health and know that eating a box of Nutri-Grain bars might not be the healthiest option, even though they're Nutri-Grain. So, thank you, Lindsay. Any other questions?
Yeah, and I think the comments regarding patient portals getting better is going to tie this next question in well. What promising advancements do you see in point of care treatments?
Dr. Goltz, Dr. Bonsack, either, or Kevin. I mean, you're versed in a lot of the same technology. So, as a patient sort of brand technologist, we'd love to hear from your aspect too.
Well, I'm not in practice now, so I'm not sure if I'm qualified to answer this anymore. But, I foresee with the advancement in technologies, and hopefully we'll start seeing better integration and interoperability with, remote patient monitoring and EMRs and telemedicine platforms and how all of these things communicate. I think point of care is, going to start to play a larger and larger role, especially as patients have access to those technologies that they can have in their home. So, Kevin, if you want to expand on that. I can say that blanket.
Yeah, so I think those are a lot of trade-off discussions too about technology, Kevin. But some of these technology exists. Like a blood pressure cuff is not new, but it is new for some patients to buy one and have it at home. And then the question is it a wrist cuff or an arm cuff? So like the things that are available to people is not always clear of what they should be using. And so that's one example, getting data points for vital signs. But some of the more critical aspects are congestive heart failure, for example. I mean, how many times do we bounce people back from a readmission because they weren't doing a daily weight? And, how much would it cost to buy a scale that has Wi-Fi that tells me as a doctor what their, weight, dripping wet when they get out of the shower every day or whatever it is. And then I can see that they bumped up 5 pounds. Okay, now we need to do an adjustment. But I don't see them until they're 15 pounds up. They've got tree trunk legs, and now it's a crisis, and we're bouncing them back in the hospital for a $10,000 admission. What? Like, let's think about where our trade-offs are. So would it be worth buying a scale with Wi-Fi for this patient on their discharge so that we could even decrease readmissions from 15% down to 12%, but in a huge population? The impact that would make would be incredible. So I think a lot of those point of care and or remote monitoring systems is huge. Really appreciate that question. And then of course, all the apps for that are out there for checking other things like oxygen levels and looking for AFib and all that. I have plenty of Apple Watch AFib visits now because everybody's convinced they have AFib. But again, just trying to hone the accuracy of these diagnostic tests or quote diagnostic tests that are out there for the consumer, and then balancing that with what we actually can then act on with evidence-based to address the needs of the patient.
And just to add to that too, how do these devices even notify the provider? So let's say they have the digital scale, and maybe the patient doesn't understand that maybe this, 2 to 3 pounds that they've gained is an issue, but the scale feeding into the physician's electronic medical record does flag, this patient's weight is up 3 pounds. You have your parameters set, and it'll flag for the patient. So we don't even have to necessarily rely on the patient's knowledge of their disease to get reliable information and to take action.
Yeah, I mean it's all interesting, and I'm less of an expert in many of these details as any of you guys. But I guess I do teach systems design, so I think that there is kind of a, if you think about it as a system of inputs and outputs, among the things that are changing here is a level of transparency. And I think for your average consumer, all of this data being available suddenly means that it's not as much of a black box process. And there's a long journey between data and some kind of wisdom as to what to do with that data. I mean, Dr. Bonzak, as you were just mentioning, right? I mean, so, but suddenly making that data available, and as you mentioned, what the P stands for, portable. You know, they say that you have more data about yourself on your phone than you typically have in your house at this point. You know, so the portability aspect and and being able to transport that information and do something useful with it is a huge undertaking. And I think, you know, as we all know, a little bit of knowledge is a dangerous thing, right? But there's no question that consumers armed with that information will start to do more and more with it, and their expectations will change. And if you factor in even the advances of technology, AI, and a lot has been reported about what AI assistants can do in the radiology field and places like that. So increasingly, right, we're going to have very powerful devices in our pockets that will start to change our understanding of what point of care actually means. And can your device actually facilitate that virtual office visit, or even in the office visit? All of these dynamics are going to change, and I think maybe even more quickly than sometimes the system, as they say, is, you know, systems are always sort of designed for the outputs that they produce that are prepared to actually manage.
Great. Those were all great answers. We did have a few more questions, but we are at time. So I just want to remind everyone that our next Lunch and Learn session will be May 18th from noon to 1 with Dr. Guy Hemproff on developing a trusted framework to improve population health management and patient engagement. Dr. Hemproff will be demonstrating how his team's work to develop accurate geotagged pandemic prediction algorithms have been used to help coordinate medical supply chains. The created framework utilizes both patient-generated and SDOH data. He will also demonstrate how machine learning algorithms can connect residents to community resources and provide customized health education aimed at increasing the health literacy, empowerment, and self-management of patients. If you're interested in registering, please visit the Michigan HIMSS website for more information. I want to also thank all of our panelists for your time today and all the great information you provided. It is very appreciated by the Michigan HIMSS, and I'm sure everyone that has attended the webinar. If anyone has any questions or needs more information, please visit the HIMSS Michigan chapter website. This webinar will also be posted there. And if you have any questions about sponsorship opportunities, please reach out to Dan Boyle at dboyle@uphp.com. Thank you all so much for attending. Have a great afternoon.
Thank you.
Thank you.